Welcome to today's deep dive. You know, when you watch a master play a high-stakes chess match, the actual capture is, well, it's really just the final step of a meticulous, almost invisible setup.
Right, the real work happens way before anyone makes a move.
Exactly. And today we're applying that exact level of strategy to the endoscopy suite. We're breaking down a great article on a structured approach to large colorectal polyp EMR, specifically those tricky 10 to 30 millimeter ones.
And our mission today is really extracting Dr. Raju's exact game plan. We want to pull out those practical tips for you, whether you're a trainee or practicing GI mastering the traditional hot EMR.
Right. So getting back to that chess analogy, before we even think about making a move with the scope, we have to look at the board. And that, surprisingly, starts with the patient's personal calendar.
Yeah, it sounds weird, but procedural safety isn't just about what happens in the room. You really need to ask about their upcoming plans, like, are they taking an international flight soon?
Or going on a cruise.
Right. Exactly. You even need to know what their home support system looks like.
Wait, let me push back on that a bit. I mean, why spend so much time worrying about vacation plans when we're supposed to be focused on, technical execution?
Well, it really comes down to the risk of delayed bleeding. A technically perfect resection it doesn't mean much if the patient starts bleeding a week later while they're out at sea.
Oh, wow. Yeah, that makes total sense.
Yeah.
Or if they live alone and don't have anyone to call for help.
Right. The setting outside the hospital completely dictates the safety inside it.
Okay, so framing the schedule as a safety check changes the whole approach.
Yeah.
But moving into the actual procedure, the text heavily emphasizes taking a lot of time to navigate the left colon.
It does, yeah. It's a huge focus.
But in practice, I mean, there's always this push to just reach the cecum as fast as possible, just to save time.
Oh, absolutely. But prioritizing raw speed over scope control is a massive trap. Taking the time to carefully navigate that left colon yields a really short, stable scope position.
Which is usually around, 60 to 70 centimeters?
Yep, around there. And that stability allows you to literally dance around the target. You can keep the lesion perfectly positioned right in the lower half of your visual field.
Right, because once you have that perfect control, you can move to the next phase, isolating the polyps safely from the colon wall.
Right, the submucosal injection. And the strategy here is to inject dynamically at an acute angle, specifically on the cecal side.
To prevent deep punctures, I'm guessing.
Exactly. And you use saline mixed with indigo carmine, which creates this beautiful Carolina blue cushion.
It's basically like sliding a custom waterbed underneath the polyp. But what's surprising here is the lifting agent itself. I mean, a lot of colleagues swear by those highly viscous agents, right?
Yeah, totally. But the text actually prefers standard saline.
Really? Why that?
Well, viscous agents create this super tense dome-like surface, and the snare just tends to slide right off it.
Oh, so the softer saline cushion actually holds the snare in place better.
Yeah, it prevents snare slippage way better. But there's a vital efficiency rule here. Your electrosurgery pedal and your snare must be completely ready before the injection even starts.
Wait, like before you even inject a single drop?
Yes. You cannot be fumbling for the pedal while your fluid cushion deflates.
Right, because that waterbed is your thermal buffer. Okay, so with the polyp safely elevated, it's finally time to execute the resection.
So for the hot snare technique, you want to use a 10 or 15 millimeter stiff braided snare, and you have to keep it perfectly parallel to the wall.
And what if you see, excessive tissue puckering below the snare when you close it?
If it puckers, you stop. You release it, distend the colon a bit with air to free up those deep layers, and then tightly reclose it.
Almost bringing it to a cold cut, right?
Right, and then you just do a rapid transection with minimal energy.
Okay, but what's the protocol if you pull back and realize a tiny fragment of the polyp was left behind?
In that case, you use hot biopsy avulsion for the remnants. Then you treat the margins with APC, use deep clips for closure, and document that clean base with 20 to 30 photos.
Wow, 20 to 30. Safe EMR really is just a strict discipline of planning, control, and absolute completeness.
It really is. And, if you want to see these exact maneuvers in action, you can search YouTube for Dr. Raju's EMR channel playlist. It is incredibly helpful.
Definitely worth checking out.
Yeah.
But before we wrap up, there's one final, pretty provocative thought for the text that I want to leave you with.
How about the prior manipulations?
Yeah. The author notes that previous manipulation, like taking standard diagnostic biopsies, makes subsequent EMR significantly harder.
Right, because it causes submucosal fibrosis. It essentially tethers the polyp down to the deep muscle wall.
Exactly, making it impossible to lift later. Which really leaves you to wonder, how often are routine diagnostic biopsies inadvertently turning a straightforward future removal into a highly complex procedure?
Yeah, it's a great question.
Definitely something to consider next time you're setting up the board. Thanks for joining us on this deep dive, and we'll catch you next time.